Clinical presentation of non-toxin mediated infections. Staph aureus can cause damage to almost every organ. It leads to a variety of infections that range from skin infections to deadly invasive infections. Some of the non-toxin mediated infections associated with skin and soft tissues are folliculitis, which is due to infection of hair follicle, where pus, blisters, erythema, and inflammation occurs. Folliculitis can progress to furuncle, which is a very painful pus-forming true abscess. It generally occurs in moist regions of the body. Furuncle can further progress to carbuncle, which is generally found in neck region. It is severely painful, associated with bacteremia, fever, chills, and subcutaneous tissue involvement. Post-surgical cellulitis, impetigo, and mastitis in lactating women can also be seen. Musculoskeletal infections are generally spread through hematogenous route. Most common of these are seen in children. One of them are bone infections, which is hematogenous osteomyelitis. It is associated in children with fever, severe pain, reduced ability to work, increased WBC count, ESR, positive biopsy for the blood culture. It is less seen in adults. For its diagnosis, X-ray is not recommended because it will not show any sign of osteomyelitis up to 14 days. While CT scan is a better choice, and if available, MRI is the best option. Septic arthritis is another infection associated with musculoskeletal system. It is seen in both adults and children. It is generally due to or post complication of invasive procedures such as needle aspiration. It can be associated with hematogenous route as well. Most common sites in it are knee, shoulder, pelvis. In this, pain, damaged tissues within the joint, swelling, and turbid synovial fluid on aspiration is seen. On aspiration, there will be more than 50,000 pmnls per microliter of that fluid. Biomyolitis is less seen. It is generally seen in HIV and immunocompromised individuals which are living in tropical region. It is associated with pus, pain, and inflammation of the muscle, and fever. Can be associated with bacteremia. Respiratory tract infections are seen in both infants and adults. In adults, it is less common, but the signs of it are similar to like a influenza flu, such as fever, purulent pus. In severe condition, hypotension can occur. It can lead to nosocomial infections, that are infections within the hospital setting, mainly in the patient that is intubated within ICU. It can lead to CA associated, that is community associated infection, can be the reason of adult associated respiratory tract infection. In infants, the clinical findings such as respiratory failure, breathlessness, pneumatocoel, that is cavities seen on X-ray within the lungs, can be present. It generally do not cause urinary tract infection, but on catheterization of the patient, this situation can be rarely seen. CA-MRSA, community acquired methicillin resistant Staph aureus, is a necrotizing pneumonitis. It causes necrotizing pneumonitis, WHF syndrome, that is Waterhouse-Friderichsen syndrome, purpura fulminans, sepsis. These all are having a 10% mortality. Bacteremia, which can be the cause of 30% seeding complications, which means bacteria up to when it is present in blood, that can be safe, but when it starts seeding in organ such as kidney or lungs, it starts causing damage to those organs. Sepsis has clinical features such as respiratory alkalosis and hypotension. Infective endocarditis can be seen in 4 varieties, that is left-sided native endocarditis, right-sided native endocarditis. The left-sided native endocarditis is generally seen in old people. I've written here young, in old individuals with bacteremia, while right-sided native endocarditis is seen in IV drug abusers. The nosocomial endocarditis can be associated with CA MRSA, that is a hospital acquired infection. Also, prosthetic valve associated endocarditis be seen. The clinical features such as valvular murmur, vasculitis, embolism, Tanway lesion can be seen in these situations. Infective endocarditis mainly. It has 40% mortality. Cons: coagulase negative, less pathogenic staphylococcus infections are seen generally due to Staph saprophyticus, that is a novomycin resistant, and it leads to UTIs, that is urinary tract infections. Staph epidermidis, it is associated with post-surgical infections, implants biofilms on prosthetic valves. Well, the main reason for biofilms making on prosthetic valve is Staph aureus. Staph lugdunensis and scaliferi is mostly associated with osteomyelitis and endocarditis. It is one of the most aggressive cons. Epidemiology. This bacteria colonizes external layer, axilla, skin, perineum, vagina, and oropharynx of up to 40% population. The colonization has an increased risk in patients of diabetes, HIV, any immunosuppressiveness, and IV drug abusers. The emergence of MRSA strain, methicillin resistant Staph aureus, has made a drastic shift in epidemiology of this disease. It is now globally present. The CA MRSA strain, that is community acquired methicillin resistant Staph aureus, has caused global outbreaks in population of every kind, irrespective of age, sex, occupation, healthy or unhealthy. The USA 300 strain has led to many outbreaks in USA, though these were mainly of skin infections, but up to 10% of these turned into lethal invasive infections. Now the cons, which are coagulase negative, less pathogenic staphylococcus, they are primary cause of post-surgical infections, while Staph aureus is the primary cause of forming biofilms on implants. Staphylococcus group is the most resistant group of bacteria. Only 5% of its strain are now sensitive to penicillin, which means it is not gonna work any longer. But still, if strains that are sensitive to penicillin should be treated with penicillin G, 4 million units per 4 hours. Alternative of it can be neficillin, oxacillin 2 gram per 4 hours, cefazolin 2 gram per 8 hours, and vancomycin 15 to 20 mg per kg per 8 hours. If the strain is resistant to penicillin but sensitive to methicillin, we can go with neficillin or oxacillin 2 gram per 4 hours, and cefazolin and vancomycin with the same dosage. Now, vancomycin is not better than beta-lactam based antibiotics. So give vancomycin only when person is allergic to beta-lactam antibiotics, allergic up to an extent of anaphylactic shock. Now, if the strain is MRSA, methicillin resistant Staph aureus, go vanco dapto, daptomycin up to 6 to 10 mg per kg per 24 hours. It will be effective in bacteremia, skin complications, and also endocarditis. Alternatives for this can be linezolid 600 mg per 12 hours, ceftaroline up to 600 mg per 12 hours, and tilavencin up to 7.5 to 10 mg per kg per 24 hours. These one are effective against both MRSA and VRSA, that is methicillin resistance and vancomycin resistance. So it is important before using these medicine to go for a sensitivity test. If these strains are sensitive to vancomycin and daptomycin, then we don't need to use these antibiotics, so that we can keep these antibiotics safe for further mutation in bacteria. If the bacteria is MRSA and VRSA strain may be intermediate or completely resistant, we'll have to use daptomycin in this case with the same dose, and it will be effective in skin endocarditis and bacteremia. Ceftaroline is one of the alternative for this. It can be used alone and in combination with daptomycin. Also, before using these antibiotics, there should be a sensitivity test for the strain. For oral antibiotics, that is for outpatient department, if it is not MRSA, go with dicloxacillin and cephaloxin, that is 500 mg each, or we can go with cefadoxin, that is 1 gram per 12 hours. Alternative for these can be minoxacillin, that is 100 mg per 12 hours, clindamycin 400 mg, and linezolid with the same dose. If it is MRSA, then go with clindamycin, doxycycline, minocycline, and linocycline. Again, the susceptibility test for the sensitivity towards these antibiotics is important, so that we can save further gaining of resistance in these bacteria. Thanks for watching.